Mine. Sorry.
Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and I also have another, you're board-certified, right?
Yes.
Board-certified OBGYN, Dr. Valieva, who is wearing the same outfit that she is wearing on the last week's podcast. Thank you for...
You're welcome.
This is a video podcast, you know that, right?
Yeah, I try to conserve laundry.
Anyway, please consider downloading and following along. We're on all the major podcast hosts, and check us out on YouTube for the video podcast. All right, Olga, I've been looking forward to this podcast for a while. We've done a lot of pregnancy podcasts, and so today what we're talking about is normal and abnormal menstrual or uterine bleeding. And what I want to go through today is, well, what's normal, and then what's not normal, the workup, and the different causes. The point of this podcast is not to go through every little detail of the causes, but mainly to give an introduction so that someone is having potential bleeding issues, they know what's normal and not, because a lot of people don't.
Excuse me. So what is a normal menstrual cycle? Everyone has their own normal, or what, maybe women in their family have done. But how we define it on a medical level is cyclical, meaning occurring every period amount of time. Oh my gosh, I'm going to say period like 20 times, right? So typically between 21 and 35 days from the start of one to the start of the next one. I know we have this magical 28-day menstrual cycle. I think I know like one woman who has that. For the most part, it's kind of variable, right? So 21 days is the shortest, meaning day one of your cycle, and then 21 days later you have the next cycle, and 35 days is longest. Anything that's outside of that is considered abnormal. How long it lasts, it really does vary woman by woman, but typically it's less than 7 days. And when you're younger, when you first start menstruating as a teenager, sometimes that can be pretty irregular, and that's just part of your hormonal system maturing. If it's longer than that, or that can be a little bit irregular or abnormal, especially if it's lasting 2 weeks, that's definitely not normal. As far as age changes, sometimes when you're younger, it's different than when you're older, and the older you get, there can be more changes in your menstrual cycle as well. So what we call this is like extremes of reproductive age. So like early as your teens or late in your 40s when you're kind of going through those menopausal changes. There's not a normal amount of flow per se. Previously, OBGYNs have tried to define it as anything less than 80 milliliters per cycle, but like who's sitting there measuring how much they're bleeding,
Not
right?
everyone's using a Diva cup.
Not then they weren't, but if you're using a Diva cup and you're putting it into a cylinder to measure and it's more than 80 cc's, that's considered abnormal. However, what we're really looking for is...
Per day or per the cycle?
Per cycle.
Yeah.
How is this actually impacting your life, right? Are you having to run to the bathroom every hour to change your pad or tampon? Are you having to use 2 separate hygiene products, right? Is this impacting your sex life? Is this impacting your work? Are you even able to leave your house because your period is so heavy, right?
Definitely have patients going through that.
How is this emotionally impacting you, right? We always talk about, physical changes, and some people bleed so much that they actually lose blood and become anemic and feel dizzy, lightheaded, things like that. So that's what we really want to know. If you've had heavy periods all your life and to you that's normal and it doesn't bother you, live your life, right? But if it's bothersome and impacting your activities of daily living in your life, then please talk to us about it. Just because it's always been that way doesn't mean it has to keep on being that way. We can help you fix that.
Yeah. Definitely is a true point that, sometimes people don't realize how much their life is being impacted by something, and they're just so used to being chronically ill and anemic. It's just their new normal, but they can hopefully be feeling a lot better if they seek help. So I put in here, I was going to describe very, medically, scientifically what a menstrual cycle is.
All right, go for it.
But I'm gonna Cliff Notes it. Basically, it's 2 phases. The follicular phase, and starts from day 1 of your cycle, and that's the day 1 is the first day of your bleeding, and that's when the new cycle starts. The follicular phase, as its name implies, is where the follicles or the little eggs are starting to be called upon to mature, based on a few different hormones, and you might hear these hormones when people talk about like hormonal testing, but FSH is what comes from the brain to stimulate the growth of the new follicles, and this increases a couple other hormones. The uterine lining becomes thicker, and as these continue to grow, there's eventually these feedback systems that surges the hormones, and that's really when ovulation happens, kind of the mid-cycle. The length of this phase can be different for each person, as cycles can be different. But this is also a part where often if people aren't ovulating, one of these very tightly regulated systems might be off by just a little bit, causing some possible drastic symptoms. But yeah, so ovulation happens, and then you enter the luteal phase, and that's when you have the increase of the progesterone from the old cyst that released the egg, turns into the corpus luteum, releases that progesterone, and helps that unfertilized egg survive until it's the body wants it to be fertilized. And so if that fertilization doesn't happen, that the hormones decrease, and then that cycles you to the next day one of your cycle, if everything's going perfectly. If there is a fertilization of the egg, and then the corpus luteum will feedback and help support that early pregnancy until the placenta takes over.
Absolutely. And really the only reason we menstruate as a species is to reproduce, right? So it's
your body trying to get pregnant.
Yeah, even if we don't want it to. So what do you need to tell us about, or what do we need to know when you're having this concern of abnormal periods? If you don't have abnormal periods, great. I think your provider probably would ask you these questions anyways during your annual exams. But if you're coming to us saying, hey, is this normal or abnormal, or I think this is heavy, or I'm missing periods or whatever, we want to know how is it different from the norm, right? Like, are they too long? Are they too short? How often are they coming?
How we just talked about normal and deviations from that.
Anything from that. What are you planning a pregnancy or thinking about pregnancy? Are you having pain with your menstrual cycles, which not necessarily related to the menstrual cycle itself, but like what are the other symptoms of that? Are you actually bleeding from your uterus, or is this bleeding from a vaginal tissue, your urethra, or your rectum? We want to make sure that we're treating or analyzing everything the way we're supposed to. What medicines are you taking? Sometimes people are taking blood thinners that are causing them to have heavier periods, right?
Exactly.
Or other medications that can throw off their hormonal system. Are there any bleeding disorders in your family? The most common one is, hemophilia, which is more common in men, but von Willebrand's is another one that we check for. And what is your medical and surgical history that could also be impacting your menstrual cycle? Sometimes seizure medication, sometimes diabetic medication. So we're going to be asking you a lot of questions that may not seem at all relevant, but trust us, there's a point to what we're asking for.
Exactly. And once we get through all those questions, the workup is going to include an exam, because we're going to look for those other potential causes of bleeding that we talked about. But one of the hallmark things that we want to do is an ultrasound, because that's the best, most efficient way to see if there's any structural abnormalities with the uterus or within the pelvis. And so that's going to give us a good look at the uterus, ovaries, and the adnex, or the surrounding area of the uterus. And so I guess one point to just to not warn people, but a lot of times the best way to look with an ultrasound is a transvaginal ultrasound. And that is with the probe that goes in the vagina, because that is going to create the shortest distance between what you're looking at and the anatomy structures and the probe, versus one that would just go in the abdomen. And so just an FYI, that's why we do it. There's also a variation of ultrasound where we can with a small little catheter push in fluid into the cavity, because unfortunately the uterus isn't expanded like it is in all the pictures where the cavity is like open like a balloon. It's a collapsed balloon. And so it's harder sometimes to delineate things with that collapsed structure, and so sometimes you need a little fluid in there to
see if there's like
to see if something is protruding when it Yeah.
And one thing to mention too, we as GYNs, we love ultrasounds because it gives us the best pictures. So say you've had a CAT scan or an MRI or whatever, and we're like, yeah, let's get an ultrasound. And you're like, well, why? I already had this very expensive test, right? Those scans are not as specific at looking at the pelvic structures because they kind of go in slices. So an ultrasound helps us see everything more clearly and just more closely than,
And they can take video
Absolutely.
with ultrasound and see blood flow.
Yeah, there's room for an MRI when we're talking about like fibroids or things like that, but for the most part, we are going to want an ultrasound. So that's why we go with that modality. So sorry about the Vag Pro, but kind of helps us quite a bit.
Yep. We'll want to do labs, look at your blood counts, look at your thyroid hormone, blood counts mainly because we want to know how urgent this is potentially, how much it's affecting you. Are you anemic? And thyroid abnormalities can definitely, whether it's high or low, cause bleeding problems. So, and then a couple other things we might look at is other hormonal testing such as prolactin, androgens or male type hormones, FSH, LH, and estrogen, but those aren't necessarily going to probably give us as much useful information.
They're more useful when you don't have frequent periods, like if you're spacing out a little bit more, not so much if you have heavier bleeding, but depending on the situation, we may or may not check them, but we always thyroid, always a blood count just to see where you're starting.
Yeah.
And then
bleeding disorders, like we talked about before, we want to know if your family has a history of bleeding disorders or if the patient like bleeds easily, and that would be like a lot of bloody noses, your gums always bleed when you brush your teeth, you've bled a lot with a previous pregnancy and maybe needed like a blood transfusion. So we want to know those things because we might order more rare things. Go ahead with what we might do for ruling out,
the most evil test.
You talk about the evilness.
Okay,
that's up your alley.
Why is that? I don't often like to torture women, but this is one of the few times that I might have to. One of the tests we also like to get is called an endometrial biopsy or a sampling of the lining of the uterus. We like to do it when you're having abnormal periods just to make sure that this isn't related to something like a precancerous or a cancerous lesion, which can be more common in women over the age of 45. So if you're having this abnormal bleeding and you're over 45, so sorry, we're going to be poking and prodding at you. And then if you're less than the age of 45 but have other risk factors that can increase your chance of uterine cancer, then we're going to be doing or recommending a biopsy as well. Of course, you can always decline this. It is an office procedure. It is painful, unfortunately, but we can help pre-medicate you. But it is pretty helpful to help us figure out if it's related to something unusual or abnormal going on within your uterus. Which kind of brings me to causes of abnormal bleeding. Why would some people have that? So one of the reasons, and that will be helpful with the biopsy, is to find out if your bleeding is caused by what we call structural causes, or changes to the lining of your uterus that could be precursor to cancer, or could be cancerous. Another one would be polyps, which is a benign growth, but they tend to be very vascular, and they arise from the lining of your uterus. And sometimes a biopsy can help us pick that up. In women after menopause, they can be cancerous, but we definitely always want to check them. Another structural cause of abnormal bleeding could be fibroids. Fibroids are benign, rarely cancerous, and they arise from the muscle layer of the uterus. And depending on their size, if they're little small guys, we don't care. And by that I mean like a half an inch or an inch, but they can get pretty big in some women, and that enlarges the size of the uterus and it causes more bleeding. It tends to also cause more pain and pressure, and if we can't feel it on our exam, then we'll definitely pick it up on the ultrasound depending on the size. And the last structural thing would be something called adenomyosis. This is a little bit of a tricky one because
the less known potential variation of endometriosis.
Yeah, absolutely. So with adenomyosis, this is when the lining of the uterus, instead of shedding as it's supposed to with every cycle, it actually burrows more into the muscle layer. So when we do the ultrasound, you can't clearly see the line or the demarcation between the lining and the muscle layer. And when that lining is within the muscle, it tends to cause more pain and more bleeding as well. The final diagnosis we can't make unless we do pathology, like after hysterectomy, but we have suspicions, and sometimes an MRI can be helpful, but at the end of the day, you really go off of symptoms.
Right. Yeah.
Some of the non-structural things would be, is there an ovulation dysfunction, or is there something within your system that's not letting your hormones cycle appropriately? Those things can be like PCOS, which a conversation of itself. That's why we
Different
check for
topic,
your,
yeah.
absolutely. That's why we check for your thyroid hormones and other hormones to see if there's any hormonal changes. If there's a bleeding disorder, like we talked about, again, medications, or potentially, what if you have an infection in your uterus? That's one of the ways we know that something's off, is if you have pain and bleeding that's especially unscheduled, that could be a sign of an infection as well.
Yeah. A lot of things, and actually I'm pretty excited to start this aspect of it because both Olga and I really care a lot about the GYN side of things too, as well as the pregnancy side, but both of us are I would say pretty stellar.
I am obviously more stellar than
surgeons.
Some other people in this room. Yeah.
I'm keeping it modest today for some reason. But we'll be talking a lot about surgeries, and basically I'm hoping to actually kind of like go through surgery consults.
Absolutely,
and give kind of the risk benefits alternatives of all these different options as we go through these different causes for bleeding. So
and each one of these causes it has its own treatment, and depending on what we find on the workup, then we can talk about, well, how can we help you with this issue, right? If you're there's medications, there's hormonal things, there's surgical approaches to helping you mitigate. And it really, again, kind of how we started, how much is this impacting your life and what do you want to do about it, right? And not everyone is going to benefit from one type of treatment, and sometimes we have to try a couple of different ones. But I think, like Eric said, each one of these warrants its own segment, and definitely something we'll be delving into, hopefully, if you invite me back in the future.
Yeah, I mean, because unfortunately we can't just go off all the women in my family have had, or all the women in my family have had a hysterectomy, so that's what I need. We kind of need to, unfortunately, do the workup, figure out what the cause is, so we can figure out the best, hopefully least invasive option for each person.
Yeah.
Perfect. I'm excited. Are you excited?
I'm super excited.
All right.
And no, it's not because of the caffeine.
Well, a quick little podcast today to talk about what is normal and not normal bleeding. So thanks for listening, and that is it for today's podcast. If you have any questions, let us know in the YouTube comments for now. And as always, the content of this podcast and video are for educational purposes only. None of the content is meant for personal medical advice. Please contact your medical provider if you're in need for personal medical advice. Thanks, Olga.
You're welcome. Anytime.
Yeah. Anytime. See you next week.
Okay.
Okay.